All right. Well, welcome back from lunch, everybody. Uh, this is certainly my favorite session of the day because we're talking about colon and colon polyps. And wow, what an incredible 2 days we've had so far. And we just found out 120 people live stream in addition to all the people over here, and almost 300 people who registered for the course. So we were getting texts yesterday during the live feed from our colleagues all over the world, but also nationally, that hey, your microphones are still on here and there. So, which was really cool because then we knew all these people were on, and then we later on we pulled the numbers and 120 people were on, seeing all this expertise. So starting off this session, it's my great privilege to introduce Dr. Jennifer Christie, who is obviously needs really no introduction. Is obviously division chief of GI at University of Colorado, past president of the ASGE, but truly one of the big reasons that we're able to allow to continue to push the envelope and do these courses is the support that we get, as Dr. Shah and Dr. Wani pointed out yesterday, from her. And she's going to talk about quality metrics in colonoscopy and how do we raise the bar. So thank you so much, Dr. Christie.
All right. Good afternoon, everyone. I hope everyone had a great lunch. We're not done. We're still driving to the finish line. So stay with us. Again, I want to congratulate and thank Sachin and Raj and Anna and Mohammed and the whole team, and Christy Click, who's up and down and all around for making this happen. And certainly our industry partners and all of the faculty who have come to visit and be with us and present and educate us from across the world, actually. And then certainly for all of you for being here to support this course. And we look forward to continuing to learn from each other going forward. So I was asked to talk about quality metrics in colonoscopy, and it's kind of strange. I'm sitting here doing this, and the person who had a big part of creating them is sitting right here on the podium, Dr. Doug Rex. And so you'll hear me refer to him quite a bit. So, and these are our objectives for the next 15 minutes or so. One, to understand the importance of quality indicators for colonoscopy. Two, to describe what the current quality indicators for colonoscopy are. And then to talk about some strategies to optimize those quality in colonoscopy. And then consider one other potential quality indicator for colonoscopy. So why do we talk about quality overall? And then why do we talk about it specifically for colonoscopy? Well, my colleagues, Dr. Rex and others, determined over 2 decades ago that there was a significant variability in terms of polyp detection rates between endoscopists' recommendations with screening and surveillance, but also the overall impact on the decrease in post-colonoscopy colorectal cancer, which at the end of the day, ultimately, that is what we're trying to decrease. Therefore, the ACG and ASGE Quality Task Force set out to define quality in colonoscopy. And again, ultimately, the goal is to decrease post-colonoscopy colorectal cancer. And that is defined as a colorectal cancer that is detected 6 months after the index colonoscopy. So anytime that is happening, typically it's because we missed something, right? And that is what we're trying not to do. So again, what I really want you to remember is that if we cannot measure it, we cannot improve it, right? So that is the whole purpose of thinking about measuring quality. And so how do we do that? Well, we use these quality indicators. And specifically, they're defined as in 3 different ways. But we use these quality indicators as a parameter for comparison. And then we define the minimum standard and measure it against, and measure performance against it. So there's generally 3 types of quality indicators. There's structural measures, which really are related to the unit and really the system structures. Outcome measures, which assess the results of care that was provided. And typically that requires a lot of data. It takes a long time, but they're important nonetheless. And then there's process measures, and process measures really look at the performance of what we're doing at the time that that care is being provided. And they serve as surrogate measures of high quality endoscopic care. So again, most of the measures that we're going to talk about are actually process measures. And then some of the detection measures are considered outcome measures. But what's really important is that regardless of what we're talking about, these measures have to correlate with improved outcomes. They should be evidence-based. And then most importantly, they should be measurable. And then ultimately, specific to colonoscopy, they are assessed to decrease post-colonoscopy colorectal cancer. So in 2006, the ASGE and ACG developed and published the first versions of these quality indicators. And then they were updated in 2015, and then most recently in 2014, specific to colonoscopy again. They're broad recommendations to address all endoscopic procedures, but I'm going to focus on colonoscopy today. But typically, they're divided into three categories based on time frame. So you have your pre-procedural quality indicators, your intra-procedural, and post-procedural quality indicators. And then also in the updated recommendations, the quality indicators for IBD are also included, which I will not discuss because that's a whole nother talk in and of itself. So just to give you an idea of the sort of the progress and the milestones that have been achieved in improving quality in colonoscopy, I mentioned to you that over two decades ago, it was realized that there's a lot of variability, and there really should not be. So in 2002, when I was just a baby, right? And why are you laughing, Mohammed?
I'm gonna get fired.
No, actually, it was like a year out of my fellowship. So I was practicing. But the Multi-Society Task Force proposed that ADR and withdrawal time be quality measures. And then more evidence was developed to support that ADR was associated with withdrawal time directly. And then initially, the ACG and ASG task force defined these quality indicators for screening only. And then over time, we looked at, the correlation between ADR and PCCRC, post-colonoscopy colorectal cancer. And then in 2015, ASG and ACG developed some priority quality indicators, which I'll talk about. And then more data was developed to support the use of ADR as well as sessile serrated lesion detection. And then also the screening rates were lowered to age 45, or screening age rather. And then also the quality metrics were then expanded to all indications for colonoscopy, not just screening, in about 2020. And then, as I mentioned, the updated quality indicators came out in 2024. And then AI, which is going to be a big part of this, which Dr. Messman will discuss, became approved around 2022, 2023. So there's been a lot of progress. I think we're doing a pretty good job, but obviously always measuring these indicators to make sure that we're pushing the envelope and really being able to deliver the best care. So in terms of pre-procedural interventions for colonoscopy, the two that are addressed in this most recent guideline is the frequency of the appropriate indication. And again, it's a process measure, and the target performance is that be the case in greater than 95% of procedures. And then the second one for pre-procedural is the rate of bowel prep adequacy. And again, that target is greater than 90%. And the rate of bowel prep adequacy is a priority indicator. The other things that I'll talk about, there's three other quality indicators that are determined priority quality indicators that I'll talk to you about. But I really just wanted to show you that in terms of when you're thinking about preparation, it's defined as adequate when the visualization is such that it's sufficient to detect lesions greater than 5 millimeters, but also and or using the bowel prep score of greater than 2 in each segment of the 3 segments of the colon. And the importance of this of a bowel prep is that if it's suboptimal, clearly we can miss lesions. It's going to reduce our ADR rate. And also we're going to inappropriately repeat that colonoscopy early. The other thing is important is that we measure not only individual bowel prep adequacy, but also unit level. Because if they're unit level issues and that we're not hitting those targets, then maybe we need to do some education around how patients are educated prior to their procedure, maybe the purgatives that we use and the devices that we use in our units to irrigate. And then the other really important thing is that follow-up interval must align with the U.S. Multi-Society Task Force recommendation on post-polypectomy guidelines. And that is really key. And if the bowel prep is not adequate, then the procedure should be repeated within a year or so. And this picture up here, this is actually a procedure I did probably about a month ago of a patient. And I'm an optimist. So I started and I was like, it's not bad. And I kept going. And the nurses in the room, they'll say, oh, that's not good. And then when they start spraying the mint room deodorizer, there's hinting to me, Dr. Chrissy, it's time to stop, right? And then finally the nurse anesthetist said, what are you doing? Right. And then first I clutched my pearls and then I said, okay, it's time to stop. And he came back a month later and it was clear and it was good. So sometimes people have to pull you back. So again, it's important that these guidelines, that the Multi-Society Task Force guidelines on colorectal cancer be adhered to as part of the quality indicator. And these are the recommendations here. But remember that it's important that these recommendations are only assuming that a high quality baseline colonoscopy has been performed. So in terms of other intraprocedural priority indicators for colonoscopy, we have the cecal intubation rate, and we aim for greater than 95% per endoscopist, and I'll show you some data quickly on that. Adenoma detection rate of greater than 35%. Now remember, it used to be 25%, but the task force has determined that there's a higher incidence of adenomas. Also, we're integrating now surveillance as part of the indicators, and so that's going to push the adenoma detection rate up, and that we really should be targeting 35% now in these patients. And then also looking at the sessile serrated lesion rate because of the increased risk of right-sided colorectal cancers, and that can be easily missed if we do not do a quality exam. And so in terms of cecal intubation rate, this was a study that looked at why this is important. As you can see, they stratified groups into a rate of less than 90% and then up to greater than 95% in terms of the mortality from colorectal cancer. And after looking at this, they determined that the patients or the endoscopists who had a cecal intubation rate of greater than 95% had an overall lower mortality rate when these patients were then followed up several years later. And then in terms of the sessile serrated lesion rate, we aim for greater than 6%, right, of colon. So it's the percentage of colonoscopies in which a sessile serrated lesion is detected per endoscopist. And we aim for 6% because of that correlation. And this just highlights that pathway of the sessile serrated lesion to cancer pathway, and that it can happen very quickly, particularly on that right side. This particular study was a study evaluating a New Hampshire colonoscopy registry in about 27,000 patients. And they followed these patients within or after 6 months, and 162 of them were diagnosed with colon cancer. And they found that for the endoscopist, and they strategized the sessile serrated lesion rate into quintiles. And the group that had a sessile serrated lesion rate of greater than 6% actually had a lower risk of post-colonoscopy colorectal cancer, and with a hazard ratio, as you see here, of 0.29. So that's where that number came from. So other intra-procedural quality indicators for colonoscopy include the percentage of patients with a positive fecal screening test with at least greater than one adenoma resected. So that's the ADR for positive stool-based tests, greater than 50%. So that's higher. And then also the adenomas per colonoscopy, that is now something that's being looked at, but it's not one of the priority indicators. What we look for a rate of greater than or equal to 0.6. And then average withdrawal time, I want you guys to remember this. It used to be 6 minutes. Now we're pushing it to 8 to really be able to see. And also considering retroflexing in that in the right side to really see the cecum really well. So from 6 now to 8 minutes. And then Dr. Rex talked about this yesterday, but really focusing on taking out smaller polyps, 4 to 9 millimeters with Cole snare in greater than 90% of cases. And so how do we improve ADR? Because we know it's really important. There are a lot of studies that indicate if we can give feedback to endoscopists, they're likely to aim for that target. People need to know what the expectations are. So physician report cards, public reporting of ADR, these water-assisted inspections, second look, I just mentioned, AI, and then also everyone in the room participating in visualization. So in terms of post-procedural QI quality indicators for colonoscopy, there's really mainly 2 in this current guideline. So it's really looking at the number of procedures or the percentage of procedures that are then recommended appropriate screening and surveillance guide recommendations afterwards, and that should be in greater than 90%. We should really think about it. It should be 100%, but we know sometimes, it's a gray area, so the target is 90%. And then also it's important to report and review adverse events with your quality committee, because then that gives you an opportunity to then look for areas of improvement. So that's something that we should be documenting and tracking on a regular basis. And then I would propose, and I mentioned this to Dr. Rex during the break, is that perhaps we need to start to think about patient experience and how we can then integrate that into quality assessment. And so the question would be, how do we do that in a way that is objective and that could be standardized? And so that may be an opportunity here. And the reason why that is important is because we know just from our day-to-day, but also there's studies to show that patients who have more anxiety going into the procedure tend to have more pain. And there was a Polish study looking at this, that patients who were they were not well informed, they were not well sedated, they weren't sure about the prep, and they had a lot of discomfort during the procedure. And this is really important because if patients are uncomfortable, they're not coming back, and they're certainly not gonna tell their friends and family to come and get it. So that, I think, is key. And so other strategies that we can utilize are having a endoscopy unit quality champion, right, or team, if you will. These registries like GI Quick help us to measure data, collect it, and look for opportunities to improve and measure how we're doing as a group. The ASGE EURP program is another opportunity where you can really track your quality measures and then aim to achieve that recognition program and be able to use it as bragging rights to say our team is meeting those quality metrics. And then, of course, staff and patient education, standardized templates and guidelines always make it easier. Clinical decision tools, and then artificial intelligence as well. And then lastly, as I mentioned, patient factors. And so just to remind you of the progress that we've made, but certainly more opportunity ahead. And overall, our key takeaways that I want for you today is that quality in colonoscopy is critical to optimize safety and outcomes. These quality indicators must be reportable, measurable, and reproducible. Education and consistency are key. And then also a patient-centered focus should be included. And then also quality-focused unit leadership is key to meeting and exceeding expectations. So thank you for your attention and thank you for being here.
Thank you so much. Thank you so much, Dr. Christie, for this incredible talk. It's my pleasure to introduce our next speaker, Dr. Momin Gabber. Dr. Gabber comes to us from University of Cincinnati, where he serves as the Associate Professor of Medicine, as well as Director of Advanced Endoscopy Fellowship and Director of Endoscopy. And Dr. Gabber is also a dear friend, and he's going to talk about the recalcitrant adenoma, EMR, ESD, FDR surgery.
Thank you, Bilal, for the introduction. And I can't believe it's already the third day and the last day of RMIE. I've been enjoying that, and I hope all the audience have been enjoying that. I've enjoyed interacting with the expert faculty. I personally learned a lot from all the interactions with the faculty and with the audience and trainees during the hands-on. So it's been a pleasure to be here. Yesterday, we had an amazing group of experts, and I had the privilege of watching them doing some of these procedures that we'll talk about. Dr. Rex, Dr. Ben Moller, Dr. Messman. They performed many of these. Today, I've been given a very ambitious assignment to cover all of these techniques in just 15 minutes. I planned the talk in a way that we're gonna go through the guidelines, through case presentations about some of these techniques and what's the best application for them. These are my disclosures and our learning objectives today, and that's the outline. Dr. Christie gave an amazing presentation about the value of colonoscopy in prevention of colorectal cancer. So we need to do good colonoscopies, detect the polyp, and we also need to do a good job to remove these polyps because to maximize the preventive benefit of colonoscopic polypectomy and screening in general, we have to do complete excision of the polyps. And the data shows that incomplete excision of polyps accounts for about 27% of those interval cancers that are detected after colonoscopy. So the recalcitrant adenomas are those ones that are challenging to deal with, whether these are because they are recurrent after prior EMR or related to incomplete resection in the initial procedure, non-lifting due to submucosal fibrosis or scarring, or if they are located in a difficult anatomical site, or if the size is too large for standard techniques, or those also who have some suspicion of early cancer. So it's known that prior manipulations of the polyp at the initial colonoscopy before referral to an expert center can really impact the ability of the endoscopist to resect these polyps. So it's very important to remind ourselves that there are certain practices that ideally we should refrain from, like snare biopsies, like excessive forceps biopsies, and tattooing in certain locations like the rectum, the cecum. There's really no indication to tattoo there. And when we tattoo, we should use good practices for tattooing. We should not tattoo the lesion itself. I think one of the lesions that were resected yesterday, there was a tattoo mark under the lesion. This is our institutional pathway for colorectal lesions referred for advanced resection. Basically, we start by reviewing the records of any referral. So we go through the history, if there is any family history of cancers, personal history, surgical risk factors that might impact our plans for resection. And then the most important part is to review the external records for the initial procedure that was done. If there is adequate photo documentation, which ideally should be a video documentation, and that's not available if it's a referral from an outside facility in most cases. But if there is adequate documentation, we can move to the next step. But if there is not, typically we do an evaluation colonoscopy with advanced imaging to evaluate the lesion and put a plan for resection. So once we are able to evaluate that lesion, again, whether by reviewing a video recording of the initial procedure with high quality imaging or performing this evaluation colonoscopy, the next step is to evaluate if this lesion has any signs of deep submucosal invasion or not. If it does have signs of deep invasion, this is typically referred to surgery in a multidisciplinary group discussion. If there is no suspicion of deep invasion, on that initial evaluation colonoscopy, we look if this lesion is amenable for EMR, which we are typically prepared to perform at any procedure. If it's amenable for EMR, the lesion is removed in the same session. If it's not amenable for EMR, it will need separate procedure planned for whether it's going to be ESD or FTRD. We do not typically perform it on the initial procedure, again, unless we have a very good video documentation of the lesion. So we can plan for that. Specifically that some of these procedures might need different set of equipment. The duration of the procedure can be very variable, especially when it comes to ESD, depending on the location of the lesion, the position of the lesion. So my recommendation is always do not cut corners. Sometimes patients might be unhappy that we cannot take that lesion out today and they have to come back, but we have to make sure that we're doing the procedure safely for them. Avoid tight schedules, which can create a lot of pressure on the endoscopist. And the worst outcome is to have a complication when you're rushed. And I had the pleasure yesterday of moderating Sessions' live case yesterday when we had this band EMR for the esophageal lesion. And really, he was like an example of like, don't panic when you have a complication. Not only that, but he was like, he had this such joyful confidence in managing that complication that it was like so much joy in the room and the bleeding was controlled and no issues. But if we're stressed, if like everyone is like asking how long is left in this procedure, I don't think we'll be comfortable taking good care of these complications. So this is something to remember when we put our schedules and plan for these procedures. So the ESGE recommends the use of high definition white light endoscopy in combination with virtual chromoendoscopy for evaluation of any lesion before we plan for resection. So these lesions should be evaluated based on Paris classification, the Codopit pattern, which we're not going to go into the details of that now, but that's very important at the evaluation time for the lesion. The rest of my talk is 3 stories of real cases that highlight the different resection challenges and the lessons that we can take home for our practices from those. So that's the first case, and of course you can imagine what this case is going to be about from the title of the case. But this is a 67-year-old patient who underwent colonoscopy 1 year ago with piecemeal EMR of a 25 millimeter sessile adenomatous polyp in the ascending colon. And on surveillance colonoscopy, a recurrent adenoma was noted at the prior resection site. An attempt at conventional EMR was made, and this lesion did not lift. So it was referred for evaluation. So this is our colonoscopy. We're looking at the lesion. You can see how the edges are kind of tucked in, and you can see clearly the scar tissue at the site. And this central area is the area that did not lift. So when we evaluated the lesion was of a reasonable size to attempt underwater EMR, and we've seen the experts performing that technique yesterday. So you fill your colon with fluid, which is typically saline, and using a snare, you decide what's the adequate size of a snare. We start on resecting the lesion without any submucosal injection. And that's what we're attempting here. The goal is to kind of get your snare around the lesion. The main value of underwater EMR is to get the lesion on block. So that's what you should aim for. You can notice we're applying some suction, typically not too much suction when we're doing the underwater technique. And then once the lesion is grasped nicely with a snare, we apply electrocautery, and the lesion is typically resected. Once the lesion is resected, you want to evaluate the resection site. And you can notice at that resection site, there is also some tattoo or previous injection from prior EMR here. And that's probably adding to the scarring and the fibrosis that was noticed in this lesion. A meta-analysis published recently in Endoscopy International showed that underwater EMR was associated with significantly increased rates of on-block resection. Interestingly, there was no statistically significant difference in recurrence rates between underwater EMR versus conventional EMR, but underwater EMR has significantly also reduced the procedure time for removal of large polyps when compared to conventional EMR technique. So a few teaching points here. Again, underwater EMR should be considered an alternative for conventional EMR when we're faced with some of the recurrent or non-lifting adenomas. Non-lifting does not always indicate invasive cancer. It may be due to prior resection, prior biopsy, or tattoo-related fibrosis. And underwater EMR avoids submucosal injection, so it facilitates the capture of these fibrotic, non-lifting lesions, and it has shown a safety profile that's comparable to conventional EMR. Our next case is cutting edge at the edge. This is a 59-year-old patient who was referred for management of a rectal lesion discovered during colonoscopy. And as you can see, this is about 40 millimeter flat, laterally splitting tumor, granular lesion in the distal rectum. But what's special about this lesion, it abuts the dentate line. So it extends to the anorectal junction. And we performed virtual chromo as well to look at the margins of the lesion. One of the advantages of ESD in these lesions is that you have really very good control on the margins. As you can notice here, we're injecting at the dentate line. And one of the benefits too is that we can mix the injectate with lidocaine to reduce the post-procedural pain, which typically, as you know, once we get to the dentate line, there will be some somatic pain sensation there. So it can be very painful for the patient. This area is also very vascular. So another advantage for ESD into that area is that you have very good control when you're making your mucosal incision. You can recognize blood vessels early. Once you recognize those, you can deal with blood vessels, so you can control your margins. If you can notice also here, when we marked the lesion earlier in the video, we did not mark the dentate line side as well. So typically we try to reduce all the electrocautery harm and damage at the dentate line to reduce the post-procedural pain, which is expected despite all of these precautions. But the main advantage with ESD is that you have very good control on the margins. I love those lesions, and typically when we do them, we do an anal incision followed by an oral incision, and then I do tunnel from the anal to oral direction until the end of the tunnel, like a bridge and tunnel method. And then when we dissect the lateral margins, I found it's very helpful to dissect in retroflexion from the oral side. So the scope would be going under, retroflex from the oral side, and you can dissect the lateral margins of the lesion. And that provides some tension and traction from the scope shaft itself. So you don't need to use any of the traction methods. This is a German study published in Surgical Endoscopy in 2023, and it compared ESD versus EMR in the treatment of rectal lesions involving the dentate line. And it showed that macroscopically complete resection was possible in both groups, but on-block resection rate was 90% in the ESD group versus 9.7% in the EMR group. So they concluded that ESD has intrinsically higher on-block resection rate, which is directly associated with the lower recurrence rate and in any part of the GI tract. And it's also not limited by the size of the lesion, unlike EMR. This is an accepted randomized control trial that's accepted in gastroenterology by the Third Space Endoscopy Working Group from Spain, and it compared ESD versus TAMAS for rectal neoplasia, for early rectal neoplasia. And they noticed that ESD has higher on-block and R0 resection rate when compared to TAMAS for those lesions. And they concluded that ESD is not inferior to TAMAS when it comes to resection of those rectal lesions. They had they randomized 73 patients into two groups, 34 for the TAMAS and 39 for the ESD group. And the local recurrence actually occurred in two TAMAS patients, but none of the ESD patients. ESD was way cheaper when compared to TAMAS, with the cost of TAMAS about 11,000 euros versus 6,000 euros for ESD. So our third case is about a scarred lesion. at the appendiceal orifice. This is a 62-year-old patient with history of a sessile polyp at the appendiceal orifice who underwent EMR a year ago. And that patient came for surveillance colonoscopy, and they noticed this lesion at the AO right there with some scarring at the edges. So conventional resection was not feasible. We evaluated this lesion for possibly underwater EMR, but the scarring and the location at the AO make it almost impossible to perform underwater EMR for this lesion specifically, although it's not that big of a lesion. You can see the AO right there, right next to the lesion. So the plan was to proceed with FTRD. FTRD is very helpful, and I'll show quickly some data that support FTRD for AO lesions. And typically you start by marking the lesion. So you want to see those markings inside the overscope cap that you're going to use so can direct you. Of course, you can see how fast we went to the right colon. Typically, it's not that easy. That's probably the most challenging part was FTRD at the AO site. And then once you get to the lesion, the area is grasped inside the cap carefully. It's mechanical grasping rather than suction, because suction can cause some other organs to be inside the cap, and that's not helpful. And then the overscope clip is deployed, and then electrocautery applied with the snare being closed, which is fitted inside the cap, and you can see the lesion is separated. Once this is achieved, we do this as a NASCAR technique. So we take that scope completely out, and we have another scope without a kit on it to go back in and look at the area, make sure there's no complications, there is no bleeding, there is no perforation. And typically you see this nice like a pericolonic fat inside the lumen, and the lesion is resected. This is a prospective multi-center study that evaluated various uses for FTRD, and they found that FTRD achieved an R0 resection rate in colonic lesions in about 80%. This R0 and on-block resection rate is much lower with lesions more than 20 millimeters. So typically we do not advise in using this on any lesion that's more than 2 centimeters in size. I think the company says up to like 3. I don't think this is realistic. In real life, typically 20 millimeters is as far as you can go with the device. Teaching points: AO polyps pose a high risk of incomplete resection and recurrence after resection. Non-lifting, scarred recurrences are really ideal for FTRD. And I'm trying to kind of move faster for the sake of the time here. This is a randomized controlled trial published in GI in 2023, comparing FTRD and ESD for challenging colorectal lesions, ones with fibrosis and scarring, and it showed no significant difference in on-block or R0 resection rates between the two techniques, but they noticed that FTRD group has smaller sized lesions when compared to the ESD group, and the procedure duration was much shorter in the FTRD group. Last part of my talk, indications for surgery, and that was the easiest slide. So there are indications for surgery. Of course, deep submucosal invasion is an indication for surgery. Lesions that are not amenable for endoscopic resection. I mean, we've pushed the limits so far. We can resect so many lesions, but still, we're not able to resect everything. So we have to collaborate with our surgical colleagues who can handle those lesions. ESGE have a very clear recommendation that for those lesions with characteristics of deep invasion, we should refer them to surgery. The ones without should be evaluated for endoscopic resection. This is kind of summary algorithm there. When we look at the polyp, typically you want to do your evaluation with advanced imaging. If there is deep invasion, we go for surgery. If it's not, it's an advanced endoscopic resection. We typically look at the size of the lesion. If it's less than 2 centimeters, is it amenable for underwater EMR or not? If it's amenable, we proceed with underwater EMR. It's effective, safe, and simple, and really fast technique to perform. If it's not, this can be a good one for FTRD, but if it's more than 2 centimeters, typically ESD is your go-to option. And thank you for listening, and thanks for the hospitality, for the amazing group here, Dr. Shah, Dr. Wani, Dr. Bilal, Dr. Deloy, and of course, Dr. Christie, for the hospitality and for the opportunity to share with you the success of your course, and congratulations on an amazing course.
All right, thank you, Dr. Gaber, for a tour de force. Whenever you have a chance, you can come up. Next is my pleasure to introduce Professor Helmut Messmann, who I think all of you know now because he did the hardest procedures yesterday, really complicated rectal ESD and a GPOM. Also has giving four talks, so he has Dr. Wani to thank for. But in addition, he is a world-renowned expert in advanced resection and former president of the European Society of Gastrointestinal Endoscopy. And I was very thrilled when Dr. Wani told me that Dr. Messmann will be joining us for this course. So he's going to talk about artificial intelligence in colonoscopy, valuable or gimmick.
Okay. So first of all, thank you for the nice introduction. Thank you for invitation, Sachin and Ray. It's a pleasure to be here. You make me nervous because you said I have 4 lectures. I have only prepared 3.
Oh, shit.
I'm wondering which is my last, but surprise, surprise. Yeah, my talk now on artificial intelligence. Yeah, is this a hype? You know this Gartner hype cycle? Or have we now a situation where many people uses AI? So I would like to ask you, is anybody who never used AI in this room? So like ChatGPT, who uses ChatGPT? Okay. Who used AI for colonoscopy? Daily in the practice? Okay. Then let's go through my talk. Yeah, I think when AI came up and I started with AI in 2014, there were a lot of publications here. And then we had a kind of hype. And now the question is where we are. Is it of benefit? When we look at publication, you see this still increasing. Maybe there is now, well, it's 25, the year is still ongoing. We are still in an increasing level. You can also look at shares to say, well, is there a hype also? Yeah, and you see there was one here and another one is here. So AI obviously is here. And I want to talk to you what is worse. So I used the first time ChatGPT, and you can use it and you can ask ChatGPT. And at that time, ChatGPT told me Helmut Messmann is not a widely recognized figure. So I thought my ChatGPT is perhaps because I was president at ESG at that time, not so valuable. I told it my colleague who is an expert in AI and said, oh, Dr. Messmann, use Perplexity. It's much better. And I used Perplexity and see it summarizes Messmann is a great expert in the field of gastroenterology. So that means AI is underdeveloped and still not there where we are. Do we need AI in endoscopy or in colonoscopy? There are a couple of points I think we will focus. Can it improve the quality? Can it be helpful for training fellows? Can it save costs? Or can it reduce the CO2 footprint? I mean, we have heard this morning, we produce so much of CO2. When I was president at the ESG, we published this position statement. And the aim was, or what we expect from AI, that we want to make an average endoscopist to an expert, to bring it to a high level. It's not the aim to make an expert better. I think this is not the realistic scenario, but maybe we can improve the average skills of endoscopy. And starting with AI, it was the first with CAT-E, the computer-aided detection, and later on CAT-X. This is in the colon where we saw in a couple of years that many companies developed their AI systems which were now commercially available. And some of you obviously use these systems. We have it all in our unit. Though the question is, are these systems helpful? And we have many trials comparing the AI system with standard colonoscopy. And I highlight here 2 in yellow because they use the same system, GI Genius, one study from Italy, one study from France, and you see here is an increase of RDI benefit of almost 15% in Italy, and a couple of years later, only 4%. So does this mean this is now the realistic scenario? Was this hype and this is now realistic? Or can be, the interpretation can also be, is the quality of screening endoscopy in Italy not as good as in France because they can improve much more with ADI? Open questions. We can improve the colonoscopy with new devices like the speedometer. You have heard the withdrawal time is an important quality parameter, and it shows you if you're too fast, slow down, yeah, but you should not stay on the same time forever and then retract very quickly. So studies show that this is a control group, the CAT-E group, the group where the withdrawal time was shown, and this is the combo group, so withdrawal time using AI, also a tool to improve. Now, what is the purpose, goal of AI? And it's not to find only polyps, it's not to find only adenomas. What we want to expect, or what is the main aim, is to reduce the cancer mortality rate, the incidence and the mortality rate, and to prevent overdiagnosis or overtreatment, and to prevent too many colonoscopies. So there was a big disruptive project, I can say, AGA, ESGE, British Medical Society, and the questions they were asked: what are the benefits and harms of AI for the detection of polyps and cancer in screening for colorectal cancer? And they used a systemic review of all available evidence from randomized trials, and they used had a new microsimulation study to assess the impact of AI on colorectal cancer incidence and mortality after colonoscopy. This is this meta-analysis, and it shows that the benefit was an increase in RDR, an increase of the APC, the harm, non-neoplastic polyps were also higher. There were more non-neoplastic resected, and there were obviously a slightly increase in withdrawal time. And this is this microsimulation, and the conclusion you see: with low certainty of evidence, adoption of CAT-E in population-based screening provides small and uncertain clinical meaningful benefit, no incremental harms, and increased surveillance burden. So there was, here you see the colorectal cancer incidence was not a statistically significant difference, and also cancer-related deaths was not different. However, the number of colonoscopies in the CAT-E group was higher, and no difference in complication rate. The ESGE published a position statement using this meta-analysis and this microsimulation. These were the authors, and not all authors, a couple of them were experts in the field of AI, but not all. And they concluded that the recommendation: most well-informed patients who have already decided to undergo colonoscopy should go for a CAT-E-based colonoscopy. This is in contradiction to the recommendation of the British Society and the American Society, because here you see the recommendation is weak for using CAT-E, and here the evidence, the surveillance colonoscopy is much higher in the CAT-E group, and there was no important difference for colorectal cancer incidence, deaths. The recommendation of British Society and also from the AGA showed they don't recommend CAT-E at the moment. ESGE said, well, in well-informed patients would favor CAT-E assistance during colonoscopy. This is already mentioned. Withdrawal time, no significant change or maybe a slight increase, and an overdiagnosis with non-neoplastic polyps, which are now resected. Another problem, which has been published recently, disc killing, which shows that in a group in Poland, the RDR before AI and after AI was compared. And the colonoscopists, they decreased in their skills. So the RDR was more worse than before. So not obviously helpful. On the other side, we have data. This is a simulation also that we can save costs, published in this series from Yuchimori. And now we have CAT-X to differentiate the polyps we detect. And should we resect all polyps if you can differentiate them? There are also a couple of devices now available from different companies. You see one here. If you see a polyp like here, and the system tells you, well, this is an adenoma, then you resect it. And if it's a hyperplastic polyp, then I think you can leave it, or you resect and discard. The different ways. This tool shows also that the benefit is not for the experts super or for the NBI super expert. The majority who has a benefit were fellows, and this is shown here in this trial again. So improvement of accuracy with AI in training, majority were the fellows, expert group and NBI group. You see only a slightly increase, and here's again the non-expert group. Coming to the last point about staging. We do a lot of AI research on Barrett's esophagus, and we could also show that AI is able to differentiate an advanced lesion, which is submucosal invasive, compared to mucosal cancer or to dysplasia. And this is also an idea for colon. And obviously, it is also possible to differentiate with AI the invasion depths of polyps. And it looks like here in this publication, the AI system tells you this is treatable or it's not treatable. Last point. If you use AI, you can rely on AI, or you can disagree with AI. And this is an interaction between AI or man-human interaction. We did a study on Barrett's, and we had a standalone performance of more than 90%. And we showed videos to non-experts, and we could show that this non-experts increased roughly by 12% in the accuracy. And this is almost the same data which Jacques Bergman published, that the non-expert increases for Barrett's roughly 12 to 15%. This was a crossover trial where the first group had videos without AI, and then with AI, and here with AI, and then without AI. And this means this will influence your decision. And it's not only the expert level, which influences your diagnosis. We always talk about non-experts and experts. It is also maybe this interaction dependent on the age, maybe on the gender, on the experience of your work in your job. So many, many factors will influence this human-machine interaction. If you have a strong opinion, you never will rely on AI. If AI tells you this is malignant, and you said, no, that's not, then you will not agree with this. And then there are colleagues who will always ask and do what AI tells them. So, and we know also from this study, here you see the CAT-X optical diagnosis. Autonomous AI means rely on AI. Whatever it tells, believe it. And here, human decides the final diagnosis. You get information from an AI system, and then you decide. And interestingly, here you see the autonomous AI was superior to what AI plus your experience tells you. So this is for the future, for sure, some very, very interesting research. And to close my presentation, I think AI works as intended. It started in the colon, which was an easy model, I would say. For colonoscopy, it's a good tool. The risks are low. CAT-E, I think those who are not so experienced, they will benefit, but the majority of experienced endoscopists will obviously not benefit. And the use is controversial. You've shown you the data and the recommendation of different societies. In the future, harm and burden of the reduction with CADX, I showed you this data. And at the end, don't forget this interaction of man-machine. And I close my presentation with ChatGPT 3.5, which shows although AI will improve, we have now ChatGPT 5.0, though there is still ongoing work, and I think AI is here, and we will use AI in the future in colonoscopy, in endoscopy, in gastroenterology, in all our daily practice. If you want to see more, I'm happy if you join next year Milan, not only for the Olympic Games, but also for ESG days. Thank you so much.
All right, Dr. Messman, that was an excellent talk, and we'll request you to stay up there for your next talk and opening the debate in the colon session, hot versus cold EMR, and Dr. Messman is going to talk about hot EMR is the new gold standard.
Yeah, talk number 3. I'm wondering when my next talk is coming. So this is now a debate, and honestly, when I flew to Denver, I realized my secretary put in my calendar, I have 3 talks, and I missed this talk, so I prepared it in the plane, and I was really nervous because I thought, oh my God, I had to talk with Doug Rex about hot and cold. These are my disclosures, and yeah, do I have other conflicts? You see, Doug Rex, he was president of ASGE at that time. I was president of ESGE. I think we know each other really good. And I think talking with him about colonoscopy means I'm nothing. He's the Pope of colonoscopy. If you ask ChatGPT, they will tell you he is the godfather or the Pope of, I mean, you have a Pope in America, yeah? And you have a president who thinks he is the Pope, or at least he posted. Maybe he thinks he's God, I don't know. But the real Pope for colonoscopy is Doug Rex, yes? So my lecture will be short, Doug, and don't expect that we are fighting right now. Nah? Cold means this is Doug, this is me. I will start with my conflict. I was involved in this guideline. You see, there are many people here, and you are just a small number in this guideline. And I don't agree with this recommendation in these guidelines. Yeah, not with all. With part of them, this is my first conflict. Then we have a nice paper on underwater. This is not a conflict. I'll just show you that I'm a believer in underwater. And this is a study, cold versus hot. We participated, so I could say I'm also, it's a conflict, being co-author of this paper. If we talk about endoscopic resection, the first question to me is always, is this resection possible and does it make sense? The aim is always to achieve a complete resection to avoid recurrence, try to get a curative resection, especially in oncology, and for sure, with a very low risk of complication, or at least you should manage these complications. And we have a couple of resection techniques, and today we are focusing on EMR, hot or cold. I think there's not so much controversy in our talk. Polyp is completely different. We have to differentiate colon or rectum, completely different organs. We have to look at the size, the risk for malignancy, and difficult polyps, pre-treated or recurrence. This is this guideline I already mentioned. horrible picture here. Rectal lesions. If it's superficial submucosal infiltration, ESD. If not, then piecemeal EMR for lesions 25 to 30 millimeter with thermal ablation. Okay, I agree. Pedunculated, we can switch with KIP. Sessile flat. I think this is the point we have to discuss. Polyps smaller than 1 centimeter, cold snare. I think there's no matter to discuss here. This is in many, many guidelines meanwhile, and I wouldn't be in a different opinion. Size larger than 1 centimeter, go for advanced endoscopy. If it's a non-invasion, if it's submucosal invasion lesion, then go for ESD. But what's with this lesion? And I think it's dependent. Sessile serrated lesions, 10 to 50 millimeter is recommended cold snare, and intermediate and larger lesions, hot snaring with snare tip coagulation. And where I don't agree is underwater EMR may be used. It must be used. That would be my recommendation, because there are more data on randomized trials, more randomized trials on underwater than on snare tip coagulation. Yeah. So I really was not happy about this statement, but I was only one person, and the majority obviously had a different opinion. This is a study from two very famous endoscopists, Christian L. and Horst Neuhaus, 10 years ago, 20 millimeter polyps. And you see at that time, almost 50% recurrence. What a mess, yeah, resecting. And then in 7% resection, despite inspicious scar, they didn't find the recurrence. So horrible complication rate. Now, thanks to the Australian group, we can decrease the number of recurrences. You see here with soft snare tip coagulation, going down from almost 30% to 7%. If you have an unblock, it does not make sense to have additional. Unblock means unblock. There shouldn't be any recurrence. For larger lesions, larger than 4 centimeters, you have a really benefit of this technique. However, when you go into detail or look in other trials, you see Australia is not everywhere. Data are about 10% with the snare tip coagulation. It's not 0%. So it's not as good as ESD perhaps. And why does recurrence occur? You see, performing piecemeal EMR, you leave sometimes invisible small spots. And there was a trial which looked at where is the recurrence coming from. It's not from the margins. Majority comes from the resected bed of the lesion. So I'm wondering why snare tip coagulation is really so effective, because they were not treated in the basis of this polyps. I'm a fan of underwater EMR, and this has been already mentioned that the godfather of underwater is also sitting here. And the reason is here, you see the muscularis propria, it's like a ring, and the mucosa and submucosa is floating. So very nice study, observation study, no perforation, the recurrence rate quite low, 5% for polyps up to 3 centimeters. And we did a lot of this underwater trials in our unit. And you see this is a lesion which is also about 2 centimeters. And I skip a bit to save time. And you can easily resect this lesion with 2 centimeter en bloc. So no need for any other technique, no need for injection. Here again, a recurrence underwater, very nice floating. Oops. I think I'll show you later on this polyp where it was resected. This is a polyp on the cecum. You will be afraid when you start your first underwater EMR in the cecum, but it is safe. I had so far one perforation, or not a perforation, I show you the video, it was a full thickness resection and the serosa was still in place. So, and here, yeah, maybe your heart rate goes up in the first time, but you see this is nicely resected. We skip this video. These are data. It was one of the first randomized trials. For me, surprising that this small lesion showed a benefit, because I would expect that polyps 10 to 20 millimeter could also be resected with hot snare in our block, but there was a difference. Our trial published 21, we could show that for the larger one, this is a benefit from my point of view. Polyps 3 to 4 centimeter, they had less pieces or could be resected more often in one piece. So the recurrence rate for this was significantly lower when we talk about 3 to 4 centimeters. And this is a pre-treated lesion. And although in this situation where you have non-lifting, and you saw this video from in the lecture before, even pre-treated lesions can be resected with underwater if they have no nice lifting. And I think although here, no need for ESD, no need for complicated procedures. And finally, the risk for a perforation, this is what I mentioned, although a flat lesion in the ascending colon, and I resected with the snare and was initially happy. And then by floating with water, you see there's the serosa still here. But as the water does not leave the colon, it was not the full perforation, and you can nicely clip underwater such a full thickness resection. Now, this is the part where Professor Rex will now continue with cold snare. I'm sure he will show you this data where I was also involved, and therefore I will skip this. Hot or cold? My answer would be en bloc, would be much easier, and not to look which technique. En bloc wherever possible, no recurrence and curative, and avoid complication. High volume, and this is a registry which we perform for ESD. The higher the volume, and this is for every technique true, the better the outcome. And I'm now trained with Professor Yahagi to get more experience with ESD, even we have a lot of experience. And this is what we do in Augsburg. Flat polyp, rectum or colon. Look at the size, look at risk for malignancy, and then go for cold snare, underwater, larger lesion in the rectum. We do only ESD. For malignant lesions, FTR, ESD. And for the other lesions, you see cold snaring underwater, piecemeal for 14 millimeters, and if it's malignant, ESD. So this is my summary. I think we have different weapons. We should use it for different type of polyps. And I think there is an overlap for some lesions, and the skill and your experience will decide which kind of technique you will use. Thank you so much.
Thank you so much, Professor Messman. I've made some calls and we've canceled your fourth talk. So now it's a true honor to introduce Dr. Doug Rex, as Master of the ASGE, former President of the ACG. ASG truly needs no introductions. 4 years of my training and 5 years of attending, I have seen so many videos of Dr. Rex doing colonoscopy that yesterday when I was in the room with him, I thought I was watching a video, and every time I had to remind that no, I actually have to participate, he's in the room with me. So I've learned, I think all of us in this room have learned from him, and I have personally been inspired by him, as developed my passion. So he's going to talk about the cold side of the debate.
Thank you so much, Bilal. And thank you again to the University of Colorado, all of the faculty. This has really been a fabulous course and a lot of fun. All the attention to detail from the staff, just been marvelous. Really, really appreciate the invitation. So I'm not going to talk too much about underwater EMR. Helmut is obviously a fan. Ken is the originator of the technique. I absolutely think it has a critical place, and everybody should really have a role for it, or a place for it in their armamentarium. I'm going to talk more about cold versus hot, and specifically with regard to EMR. Now, my talk title was Cold EMR is the new gold standard. And I took off a couple polyps yesterday using electric cautery. I don't think it would be credible for me to suggest this, and I don't believe it. I do think that cold resection is the workhorse of colonoscopy. I'm actually not an advanced endoscopist. I do mostly colonoscopy, some upper endoscopy. I do endoscopic procedures every day. And I sometimes go through 15 or 20 procedures and don't use electrocautery at all, because the great majority of what we see in screening and surveillance are small polyps. So cold resection is absolutely the workhorse of colonoscopy. And the question, I guess, is how far can that go? And do we have the right balance? And certainly there are times when we need to use electrocautery. And I talked about this yesterday, that hot snaring cuts deeper. I think that hot electrocautery is important anytime we have a suspicion of cancer. And I also talked about, this group of lesions that I would say we need to use electrocautery, another group for which cold snaring is clearly the best, and perhaps a group where there's some controversy. So I think with regard to cold EMR versus hot EMR, what we're talking about is which is appropriate in our practice for lesions that are 20 millimeters and larger, lateral spreading lesions, and adenomas. I don't even use the term lateral spreading lesion for serrated lesions. We just talk about them as serrated lesions, and for the most part, we take them out cold. So this discussion really applies to adenomas. So here is the homogeneous one. This is the homogeneous lesion with a nodule in it. And I actually not going to present the details of the 4 studies, but in the German study, this was a lesion that had a particularly high recurrence rate when it was removed with cold resection. And over here, the flat elevated non-granular lesion, and this lesion down here, the non-granular with pseudodepression. So if we give everything over here on this side, just acknowledge that we should be removing it hot, many times including some type of EMR, whether it's injection or underwater. This group, probably we can have some agreement that cold snaring at least has a role in. I would say for some of the flat adenomas in the 10 to 20 millimeter size range. I know the ESG says remove all those with heat, but I don't, that's not been our experience or what we found in our studies. And then we're going to focus on this group, which is really the main group. And if you look at these 4 randomized controlled trials I mentioned yesterday, they're consistent in their results. The risk of recurrence is higher with cold EMR, and the chance of complications is lower. So the granular LST that is homogeneous. So this is the one set of lesions, which, as I said, it's the largest group of the lateral spreading lesions. So a lot of people in clinical practice are going to see this with some regularity. And it has a very low risk of cancer in it, 1% or less. And when you're dealing with flat lesions, we've alluded to this several times, that when you look at the surface of them, in general, what you see on the surface is going to be representative of the final pathology with regard to cancer. That's not true for bulky lesions. Bulky lesions that would be a nodule in an otherwise flat lesion, a sessile lesion, a large pedunculated lesion, very hard to predict the risk of cancer. But if you get a granular homogeneous lesion with no nodules in it, and you look carefully across the entire surface of it, and you don't see any vascular disruption, you don't see changes in the surface pattern that are concerning, it's very unlikely to have cancer in it, 1% or less. And so now the question is, because we don't have cancer in it, we're going to have some reduction in efficacy if we choose to remove it by cold resection, but we're going to have this very low rate of complications. Now, I will say, when I remove things cold, I don't even think about complications. I don't worry about it. I don't care if it's Friday night. Whenever, I'm not worried about complications when I take lesions out cold. And in fact, there's strong evidence that that's true. And I think if you do the techniques well, you'll almost never see complications from cold resection. So why would you choose the complication side over the efficacy side? Well, as I mentioned before, one of them is that you just can't afford to have complications. And I think for those of you that are fellows, when you go out and practice, this is going to make a difference to you, because if you're in a town of 40 or 50,000 people and you have a complication in the high school football coach, nobody understands that you may have done absolutely nothing wrong. And everybody in town is going to hear about it and wonder what happened. Whereas there's something that happens with the population. You get into a town of 1 million, 2 million people, you have a complication, nobody finds out about it except the patient and their family, because information just doesn't diffuse in the same way. You don't have to worry about the hit to your reputation. So I think this is a reality that people are concerned about. The patient could potentially prefer a lower risk of complications. I have people that come to me, they find your name on the internet, right? And they come from another state with a granular homogeneous lesion that's 10, 12 centimeters in size. It's going halfway around the right colon. It's going over multiple haustral folds, and they've been told that they need to have surgery, and they don't want to have surgery. We've all seen this kind of patient, right? They're going to do anything to avoid having their colon removed. Well, this sort of patient might themselves choose the lower risk of complication. And you know that they're engaged enough that they're going to come back for follow-up. And in fact, the recurrences when we take things out cold are typically very small and easy to treat. So here is a granular homogeneous lesion that is in the right colon. It goes about halfway around the bowel, and it extends over a couple of haustral folds. And I was mentioning yesterday that when you're going to remove lesions with electric cautery, you're trying to decide between cold and hot EMR. One of the questions that you're going to ask yourself is, can you close the lesion? If you can close the defect after you remove it, you can get the complication rate down close to what it is with cold resection. But there are going to be times where you're going to look at a lesion, you're going to say, I can't close it because it's too big, or it's in a really crazy position, or I'm working in the ambulatory surgery center and my partners are going to be upset if I put 5 clips on this lesion in this setting, and I don't want to have to go to the hospital and reschedule the procedure. So I decided in this particular case to remove it by cold EMR, accepting that I'm going to have a higher complication rate when we do this. Now, this is I don't know that it's really a time-saving procedure. I will say that you save time because you don't have to close it, and you save money. There's a cost-effectiveness analysis that suggests cold EMR is actually cost-effective to hot EMR, because one of the main drivers of EMR costs are the costs of the clips to close the lesion. And the only time I would use clips on a cold defect is when there's an arterial bleed, which is persisting. Most arterial bleeding, if it's minor and stops on its own, you don't even have to clip that. So we only occasionally place clips. This is a really big defect. And you saw some methods here. We could potentially close this, but it could also be a challenge. And here's the patient 6 months later. These scars from these enormous lesions, the retraction is remarkable. The scars are always very small. So here's the ileocecal valve, here's the scar, and here's the recurrence. And sometimes there'll be 2 or 3 recurrences on it. And now I would switch to electric cautery to remove the recurrence, and typically close it afterwards with clips. And the beauty of this is that you've now gotten through the entire process without any significant risk of complications. I think anecdotally, I'd have to look at the data, but in my unit, we have treated several hundred recurrences over the past few years. I can't remember a single complication from recurrence. We take them out with electric cautery, we burn up the margin, and we close it with clips, and the patients always do fine. So essentially, by going cold in the initial resection and then treating the recurrences with electric cautery, we've eliminated the risk of complications. And if that's your priority, which it could well be, if you're in that town of 50,000 people, you might choose to become an expert in cold resection as a way of making your practice as safe as possible. Okay. So I think there's several ways to approach this whole thing with large homogeneous granular LSTs, because again, I would sort of say if it's not homogeneous, probably electric cautery is really the way to go. Refer them all. use electrocautery and close it if it's proximal to the splenic flexure, resect it cold and bring the patient back and be able to manage recurrences effectively. You need to be able to do that. And something that I'm increasingly seeing in my own practice, people in the community, they may be on their learning curve for cold EMR, but I think this is okay. They do the initial resection and they send it to me to do the follow-up. And I don't really think that's bad. I would rather have any combination of partial resection, incomplete resection, do this and send it to me for follow-up than send it to surgery, because the outcome for the patient is going to be the same. So I would conclude cold EMR is not the gold standard for efficacy. It is the gold standard for reducing complications. And depending on your practice, you're going to weigh those things differently. If lesions are equally well treated by hot and cold resection, you would choose cold resection as the preferred treatment. If you can't cut something cold, or it's associated with a high risk of cancer, electrocautery is preferred. And perhaps there's one group of large lesions that you would see in practice, the homogeneous granular LSTs, where you could treat it cold or hot, depending on the preferences of you, the patient, the likelihood of adherence to follow up, the, I guess, individualizing the decision for the patient. Thank you.
All right, thank you so much for this excellent session. We'll open it up for any questions from the audience, and obviously, any you'll feel free to use our online links to and Poll Everywhere feature to send us questions as well.
Mohamed, can I start with a question for you? So you have mentioned that if there's deep submucosal invasion, evident, and the sensitivity of the changes that we look for of deep submucosal invasion, the NICE-3 or the JNET-3 changes are about 50%, but the specificity is extremely high. When we see that, it's very reliable that there's going to be deep submucosal invasion. So you mentioned that the ESGE says, we should send the patient to surgery, but we've also seen studies primarily from Europe and a meta-analysis showing that if deep submucosal invasion is the only adverse histologic feature, that the risk of lymph node metastasis is still very low. It's 2 or 3%. And so in some instances, we could see deep submucosal invasion and still, if it's not a very big area, and still elect to resect that lesion endoscopically and find out if it's the only adverse histologic feature. Would you agree?
I agree. I think it depends on how it looks endoscopically still. So if you see like ulceration, for example, and you see that there's clear fibrosis in the submucosal layer, which is basically that's the protective layer to keep the integrity of the wall.
Okay, so ulceration is almost always present when there's NICE-3 changes. There's almost always some sort of depression. And how do you know about submucosal fibrosis until you take it out?
Again, I think like deep ulceration, like that lesion that I showed the picture of, I think there is very high risk if you try to resect this lesion endoscopically. We've published with the Cleveland Clinic on esophageal neoplastic lesions on top of Barrett's, for example, and it showed that it's actually even safe if you suspect deep invasion. Like example is like if you suspect a T1B versus a T2, and you're able to do ESD and get the lesion on block, you give the patient the advantage of possibly avoiding surgery if it's like a superficial, like a T1B SM1, for example. But on the other side, I think if it's a large lesion and there's clear deep ulceration there, do you think it's safe to resect the lesion? And what's the risk also if you resect that lesion and the patient runs into a complication like a serious perforation? So,
well, I think it has to be small. I think it has to be a relatively small area. But we see a group of polyps that are small, that have deep submucosal invasion that we can remove by FTRD.
Yeah.
And we see a group of lesions that have a small area of cancer where we can remove the benign part by EMR and then remove the area of cancer by full thickness resection. And I think reasonably safely, that whole process. And then we can decide whether or not we need surgery.
I think it comes to if you think you can remove it safely. I think there is an advantage that possibly the patient would avoid potential surgery and you get the the benefit of getting a definitive diagnosis, which you always tell the patients upfront. Even biopsies are not gonna give you a definitive diagnosis for the lesion. So, and again, Dr. X, it's hard to disagree with you, so I'll have to.
Well,
I'll use that opportunity to ask a question for you on your talk, because there's that interesting part. First, I think your referring physicians would appreciate so much that you would accept those lesions who've been resected and coming back for recurrence. There is a great value for that. But do you think that now, if we are making it like standard of care for anyone, even if they think they cannot completely resect a lesion up front? We're talking about those in smaller practices, in remote areas, and a gastroenterologist who has a very limited experience with EMR, and they see a lesion. Typically, we tell them, if you think you cannot resect the lesion completely, you want to refer this to an expert center, because the best chance at complete resection is the first chance, right? That's the best
I mean,
attempt.
I agree with that entirely. I just think that we have to be careful about our bias that comes from tertiary centers. We don't know when we see these people with partially resected lesions, and we complain, about what's been done to the lesion. First of all, we don't know how often the doctor was successful resecting other lesions. Having that service in the community is important in a lot of small towns. We see a lot of people that come from the small town to get their lesion removed, and they never come back. They were scared to death coming to the big city. It's crazy, because some people will fly from the other side of the country, and some people think driving an hour from their small town is absolutely frightening, right? So I'm just saying that we want those people out there. I agree with what you just said, that people should, if they don't think they can get the whole thing, they shouldn't start. But we also don't know that sometimes they started and then they just got stuck, right? And we want them to send the patient to us and not the surgeons. And a lot of them are still going to the surgeons for a variety of reasons.
Comment.
Please don't.
Yeah, I wanted to jump in because I've been on both sides of that, right? I've started a polypectomy that I thought I could do it, right? But for whatever reason, the location, the movement, whatever, patient's unstable, can't. So I've referred out, or not referred out, but referred within my group. And then I also have received patients who don't, to me, the polyps are, average size, but I still appreciate that whomever the patient saw initially felt that they could not do it and just felt that it was the right thing to do. But I think, to your point, not only are some patients afraid to come, they literally cannot. Right? They don't have the money. They don't have a driver. There's a resource access issue that oftentimes we don't think about, but they literally cannot, even if they had the courage to do that. So I think the community docs understand that. They have a relationship, and they try their best to help that patient. But if they can't, then they get them in the right hands.
I think I want to make a comment on the deep submucosal invasion. I know we have a lot of questions, so I want to get to those as well. So for the deep submucosal invasion, actually, Dr. X, I actually agree with you on that, because it's hard to disagree with you. No, not really. But I do think, because I think there's more and more data that we're finding out that once we remove these malignant polyps, which you've defined in your papers as those that invade the submucosa, that we looked at all the histological factors like lymphovascular invasion, tumor budding, perineural invasion, and we don't know. Historically, we thought if it's greater than 1,000 microns, the risk of lymph node metastasis increase. But now we're getting more and more data that perhaps submucosal invasion alone is not a predictor. So I actually do think that if the polyp is 1 centimeter, 1.5 centimeter, I will definitely try to FDR it. We've also published a hybrid ESD FDR technique. One of my former fellows, Rahul, in the audience has led this, where we make a submucosal incision and then put the anchors of the FDR on that incision so that we don't lose grip, and we've resected that. I think that rectum, this becomes really critical, and we can even do, and we've done polyps where we've done intramuscular dissection. And, Carrie's one of our nurses, she'll tell you, like, they're all getting tired after 5-6 hours, but we keep going because sometimes that is pseudo-invasion, and rectal surgeries are so high morbidity that that's a difference. So versus if someone has this polyp in the ascending colon, where the stakes are lower for the patient for getting right hemicolectomy, I may have a I may send them, I have a lower threshold to send them to surgery. But in the rectum, I actually keep pushing the envelope as much as we can for that very reason.
These are good points, Bilal. Helmut, did you want to comment?
Well, I completely agree. There is no reason to send a patient to surgery if I think it's just a deep submucosal infiltration, because we can, in the majority of cases, we can perform diagnostic resection and then decide, are there additional risk factors beyond the submucosal infiltration? And in the rectum, I think organ preserving, this is the key, is important in the rectum. We do have a couple of new techniques like EID. So I really tried to really resect almost every lesion where I'm sure there's a maximum T2. I don't rely on MRI, by the way. So I do an endoscopic ultrasound, or in case, I just do endoscopic resection. And in the colon, it depends on the size, on the location. Sometimes FTR or hybrid FTR can be a tool. And it's dependent on the patient's opinion as well. I think we should discuss with the patient, because surgery, I would say, on the ascending colon is not comparable to rectal surgery. No, it's completely different.
Helmut, we've got a question here in the box, and I think it's a good one about cost. I think one of the things about AI as a tool for detection that we've never seen before with electronic chromoendoscopy is that everybody's trying to monetize it. And you know, we're in the United States, we're asked to pay for it. I think Fuji has perhaps offered it, you know, as just part of the package, but it's not the same as, like, you know, when narrowband imaging came out. It was just in the scopes. You could push the button and there it was. You didn't pay anything for it. So now in the United States, people are paying for it, and a lot of people are kind of reluctant. We don't have CAT-X yet. Because the data has been so disappointing, the FDA won't approve it. So what's going on in Europe with regard to the cost of CAT-E, and fill us in?
The majority of patients, if you ask them, are you willing to pay for, because it's not reimbursed, the majority has no interest in detection with AI. So I said the benefit for AI is for an expert, and if you offer colonoscopy in your practice, the patients think you are an expert. If you use AI, they think maybe you're a beginner.
What about the endoscopist, though? Does the endoscopy unit pay to have the AI units? No, you're not paying.
No,
because we're paying. We're paying a lot. And it's
to pay for the device.
We're paying for the device.
Yeah, we have to. I mean, I have the Medtronic system, I have Olympus, but this is mainly for research. But if you work in a hospital, you have to pay for this.
So what are most people doing? What are the most endoscopists in the endoscopy units? Are they paying for the boxes?
Yeah.
They are.
They are.
Okay. And there's no reimbursement. Okay, so that's fairly similar to here. I tell you, I use it and I'm completely underwhelmed by it. And it misses a remarkable amount of stuff. And I think one of the concerns that I have is that, unlike any other detection tool that we've ever had, it is lesion specific. It's only going to detect the lesions it was trained to find. And it was not trained to find large flat lesions. And those are the most important lesions that kill people after colonoscopy, right?
Yeah.
Everybody sees the big bulky lesions. It's the large. Okay.
You're the Pope.
But the large flat lesions are the ones that I mean, we have literally tens and tens of videos of very clear, particularly serrated lesions, but also adenomas, no signal from the box.
Yeah.
It's a problem.
Value. Well, that's where the value possibly is, right? And so if they can improve on the sessile lesion detection rate, but also figure out how to make us more efficient, and then be able to potentially do more procedures. And then that's maybe where the cost, you get the cost benefit. But it seems like the reimbursement from payers, that's not going to happen anytime soon.
Yeah.
Dr. Christie, question for you. You mentioned in your talk about the quality indicators about retroflexion in the right side.
Yes.
Do you think that that's something we should do in every colonoscopy, or just 2 looks in the right colon is equal to doing a retroflexion?
Yeah, I think if you do one or the other, is reasonable. But for the conversation we just had about those flat lesions in the right colon, there has to be, enhanced inspection. So whether it be retroflexion or 2 looks, maybe eventually AI, I think it's going to be important. But either or.
So excellent presentations and a phenomenal session. I think learned a lot obviously here. Dr. Messman, you said something in your conclusions that I found a little controversial. So I was hoping the panel could expand on it a little bit as well. But you mentioned that for endoscopists, if I understood correctly, with low ADR, perhaps CAD-E could be a good tool for them. But also earlier, there was a study that you also mentioned of how it can de-skill. So, I guess, Dr. Christie, Dr. Rex, I mean, do you think that that's the right approach to someone with a low ADR, is to give them CAD-E? Or is it better that we have some system in place to better train before they get CAD-E?
Well, the literature supports that if endoscopist has a low ADR, that person has to undergo remediation.
Right.
Right. And their units, first of all, there's some individual accountability and also unit accountability to prove that remediation worked. So education, I think, adding again, we cannot argue against technology, right? So maybe adding improved AI can help the endoscopists and help the units. But at the core, the endoscopist detection skills have to be addressed.
I mean, I think there's overall pretty good evidence that CAD-E is more helpful to people with low baseline ADRs than it is high baseline ADRs. I think overall, when you have somebody with a low ADR, you have to take kind of a multi-pronged approach, and I'm not sure CAD-E is enough of a fix. Obviously, we first look at withdrawal times, and if the withdrawal time is short, that the doctor has bad technique. And the best thing is proctoring that is focused on technique, because the basic technique of you look behind all the folds, you get the colon distended adequately, and you clean up the poop, and you wash it all down and you clean it up. And that's still the fundamentals. That's people have been getting ADRs of 50% for decades with that alone. So I think you need to focus on that. But then there's a whole variety of tools that you can pull in, including mucosal exposure devices like endocuff vision or a cap on the end of the scope, and then the highlighting tools. We've got lots of highlighting tools now, electronic chromoendoscopy, et cetera. So I think a multi-pronged approach is the best, but CAD-E is one option, and I agree that the evidence suggests that it's going to help low detectors more.
But I think there's no controversial. I mean, as I said, low performers, they will increase, and this killing is experts and non-experts. After you take them the CAD-E, then they will get worse in her detection rate, independent of their experience level. Yeah. So this is, from my point of view, not a controversial conclusion.
Thank you.
Ken?
I just wanted to make a comment that dovetails on your comment regarding the importance of a clean colon for optimizing your ADR. And this particularly pertains to SSLs. So I think the reason why AI often fails to detect SSLs is because there is usually a mucus cap. And that's a good thing for us who know to look for that mucus cap. And one of the things that I've discovered since doing global water exchange colonoscopy, so I basically don't even put on the gas throughout my entire colonoscopy on advancement and withdrawal, and I discover a lot of SSLs. And the reason why I see them is because I have such a clean colon, and then on my way out, I'm using the water jet to sort of wash off any residual mucus. And if I see some mucus that's still adherent, I'm looking for an SSL, and it usually is an SSL because it doesn't easily dislodge from the mucosa. And that alerts me that that's an SSL. So that would be, for me, an important thing to look for is this mucus cap that can, in my opinion, can be enhanced with underwater colonoscopy as a diagnostic procedure. But then on the therapeutic side, I have to say that these SSLs are the easiest to remove underwater. I mean, they literally just scrunch up. You just catch them so easily, and you get these really unblocked. These are these really big lesions that when you give gas and they look 4 or 5 centimeters, and then when you go underwater and the lumen contracts, these things kind of shrivel up, and you can get these giant lesions with even a 20 millimeter snare. It's unbelievable. So I would say those are the best lesions to start with if you want to start doing underwater EMR. Start with those SSLs. And so I just have a little bit of issue, Doug, with your recommendation that we use cold snaring for these SSLs, because these SSLs are usually pretty flat. And when you're doing cold snare, it's usually with gas. When I've tried to do cold snaring underwater, I've gotten into trouble because I can't cut through them because it catches too much tissue. Even that lesion hunter that is purported to cut through anything, because it worked kind of like a mechanical lithotripter where it's pulling the snare forcefully against a metal edge, it gets entangled, and there have been cases where the wire is snapped and I have these loose ends, or where I can't even open the snare again and I'm stuck. It's entangled in the lesion. So that's where I would just say a word of caution about following that recommendation for using cold snaring for SSLs, because you seem to have become a big advocate for that. I've heard it many times.
I am a big advocate, and I will tell you what I think is the other side of it, which is that I think SSLs, individual SSLs that you look at are actually incredibly low risk lesions. So if you look at the prevalence of cancer in SSLs, compared to adenomas of similar size, it's about 1/7. So if you look at the molecular pathways of post-colonoscopy cancer, at least in some studies, SSLs contribute disproportionately to the occurrence. But I don't think that's because we're not getting SSLs out effectively. It's because when we see one, there's often another, and we miss it. And so missing is the biggest problem with SSLs. So the question becomes, can we get them out safely? And I would say you can look at tons of SSLs and say, I use this term, zero risk lesions. This is a lesion that has zero risk of cancer. Under those circumstances, Ken, and this may be a difference, I no longer care if I actually get it out on block. I want to get it out. We've got good evidence that cold resection piecemeal has very low recurrence rates. And now I don't have to worry about a complication. If we're going to try to get them all out on block, 20, 30, 40, 50 millimeters in size on block using electric cautery, now people are going to be throwing clips on them afterwards to prevent them from bleeding. And there are going to be some complications. So in this trade-off of complications versus efficacy, I think, maybe there's some uncertainty about it, but I think it could well come down that cold resection, even piecemeal, no clipping is effective, cost effective. And again, individual SSLs are actually very low risk lesions. I take them out and we bring them all back in a year. We don't bring them back in 6 months. Take them out in the 10 to 20 millimeter size range piecemeal. I just remind everybody we have no guideline that says a piecemeal lesion under 20 millimeters has to come back in anything less than 3 years. And I just never get in trouble with it. So that's the other side of it. I see your point of it. Yeah, I see your point, but I think my approach to it also has some merit and some rationale for it.
Will the panel allow me to make a short rebuttal statement at the risk of this becoming a debate between Rex and myself? But and so I just want to say that what I see a lot of in my practice is solely I don't do any screening colonoscopy. So these are all referred from other gastroenterologists, and they will report other SSL lesions they've removed, often with clips in place that they've placed. And I find a lot of recurrence, at that side. What I'll do is I'll just snare the clip with the surrounding tissue underwater, and I'll send that off. And I can tell you, it pretty much predictably, there'll be some recurrence. And it's so much so that I rely really on the near focus and NBI to identify the perimeter of these SSLs. And I will put dots around the SSL so I am sure that I'm getting the entire lesion out. And I even will do Burke's hot snare tip cauterization, which I normally never do, but I make the exception for these SSLs because they sometimes have these little islands that come off, they're so irregular in their outline. And I have seen patients come back with cancers who had SSLs. So maybe the impression is that they're zero risk or almost zero risk. Certainly in the sigmoid and rectum, that would be true. But I've seen enough of those cases where they became later on cancers that I am very vigilant about them, and I take extra time.
I acknowledge what you're saying. My point is, Ken Binmuller can look at a lesion that's an SSL, predict that it's got zero cancer, and what you take out and send to the pathologist is never going to give you a surprise at that time. Now, maybe somebody else, leave some of it in place and eventually it turns into cancer. And I totally understand what you're saying about going around seeing scars with little foci of residual SSL. I get that. And I'm not totally sure what to say about that, except I don't want to be overdriven by the power of the anecdote. We all try to go with what's available in the data. And the observational data in tons of studies now is that overall cold resection of SSLs is pretty darn effective. I'm sure it's not as effective as Ken Binmuller taking them out en bloc, but
those are the lesions that I think you really could start with. I think those are the safest to start with. Was one of the comments I wanted to make. Thank you.
I'm going to continue this debate. No, I'm kidding.
It's a good debate. I appreciate the discussion. I mean, right?
This was fantastic.
We're all learning from the discussion.
So I have a question, Dr. Christie and Dr. Rex. You guys have been past presidents of our GI societies, and we've all been a part of all these quality indicator documents. And it's great to come up with a list of quality indicators for our endoscopic procedures. So I have a question with regards to the implementation aspect of these quality indicators, right? Do we have any idea how many endoscopists performing colonoscopy or other procedures? Let's focus on colonoscopy. How many of them are actually getting a report on their ADR? Let's just focus on this most important quality indicator, ADR. And what are the things that we can do? I mean, all these documents have like 15 to 18 quality indicators that get published. That's number one. And the second is, how often are we actually paying attention to the low performers? And what are we doing to address the performance when ADR is 15 or 20%? Thoughts on that?
Yeah, I'm sure you have a lot to say about this.
No, you go ahead.
But I think we still don't have a lot of answers to your question. I'll start there. As far as the quality indicators and the length of them and so forth, in Doug's paper with the rest of the task force, they actually are focused on these priority indicators that I mentioned, right? And so you get those four baselines, so cecal intubation rate, ADR, now the SSL serrated lesions, and then the what was the I forgot the first one I said.
APC? I don't know.
Yeah, the adequate prep. So and then once you get those core measures, because those are the ones that have been associated with the incidence of post-colonoscopy colorectal cancer incidence and mortality, and they're measurable, and there's too much variation, right? Then you start to expand on all those other things. So I think I can answer that second question. As far as the number of endoscopists actually measuring, I don't know that. Do you have a sense?
So about a third of the gastroenterologists in the United States are participating in GI Quick, which is the biggest registry right now. And we did a web-based survey that suggested that it was a little bit less than half. That means half the gastroenterologists in the U.S. are not participating or not saying that they're participating. But we live in the United States, right? I mean, we don't have a nationalized health service. We don't have some federal regulation that says you have to do it. I mean, you have to applaud the people that are doing it because it has a cost associated with it. GI Quick is not cheap for that matter. And there are a lot of people that won't spend the money to do it. So they could be doing something, but they're not saying that they're doing it. And I think that that's really problematic. Now, how to enforce it, I don't know. The whole idea of priority indicators was that you would focus on these and realizing that almost nobody's probably doing the ones that are not priorities. They're probably mostly research questions for people to look at and sort of test their feasibility. But yeah, so going back to the answers to the previous questions, I think individual units have to figure out what to do about low performers. And there's a lot of mixed experience. There's a lot of literature about it. I think the best data in the world is from the Polish Michael Kaminski's group, where they've shown with sort of a comprehensive program that they can improve ADRs, and and this was on the slide that you showed, because in 2017 he showed that when doctors improved their ADRs, their patients' risk of post-colonoscopy cancer went down. It actually works. And anyway, does that kind of answer the question? I mean, like I said, we live in the United States. All we can do is put these things out there and hope that people and healthcare systems are going to do them. I think there's a lot of potential for things like natural language processing of electronic medical records and linkage of these pathology and endoscopy records within large electronic health records to automate the whole thing. When somebody can do that, that'll be an enormous contribution. Yeah, it's still a problem. I will tell you that I do medical legal work. And almost most of it's with colonoscopy. And I ask every time there's an interval cancer whether people are measuring their ADR and when they started measuring the ADR with regard to the case. And I just say, I won't defend you if you aren't measuring your ADR. If you're not showing enough interest in the primary function and purpose of what we're trying to do, keep people from developing cancer by measuring your ADR, I'm not going to help you with all the, by quoting all the literature that says colonoscopy is not perfect, because it ought to be as good as you can make it.
I know that Dr. Edmundowitz has a question. Before you ask this question, I just want to take a moment to recognize that outside of DDW, RMI is probably the only other place where you'll see 3 ASGE presidents, 1 ACG president, 1 ESGE president, all interacting in one conversation. So 4 minutes of Dr. Edmundowitz.
So it's a difficult conversation because this has been hovering since 2015. What are the societies doing to retrain the physicians that have low ADRs? We have almost nothing to offer our constituents, and it's really difficult. I've been involved in these assessments and had patients that have had difficulty with recurrent, with interval cancers. And when we've looked at people, we've offered them to, go to the ASGE masterclass on colonoscopy, but there's no remediation. There's no way to test people afterwards. Don't we think that the society should become more involved in at least that process?
I'll take that. Yeah, you've been involved in these discussions as well as I can, in terms of these words that we use, like certification and credentialing and all the implications that are associated with them. in all fairness to the societies did form GI Quick, right? The ACG and the ASGE did that. The ASG does have the EURP program and actively encourages people, to become engaged in quality measurement and to be able to advertise and, put a sign up on their endoscopy unit that says, we're measuring quality and we're meeting quality standards. But I'm not exactly sure how far you would take it. I'm not sure that we don't do a lot of remediation too. There's a huge amount of quality teaching that's available on GI Leap and a variety of other sources within the ASG as well as the ACG. I speak for the ACG about quality and colonoscopy, on a regular basis. So it goes the way a lot of things do in medicine. Some transitions are frighteningly slow.
I'm speaking to the other side of Sachin's question, which is why don't we have some mechanism to help people remediate?
You mean like some kind of formalized mechanism like inter-society wide?
Yeah, low ADR performers, come to this course, come to this test, go to this lab, and we'll get your ADR up.
Yeah. I
It's
would
pretty
love that.
simple.
I don't know how many people are going to raise their hand. I'm a low performer.
No, I'm telling you, directors of endoscopy labs were contacting me when I was president and say, where do I send my faculty? Where do we get help?
Yeah.
And I had nothing to offer them.
It's funny because I don't get that. I don't get that request. I think a lot of the people that are the problem. If you look at GI Quick, there's a huge percentage of people that are above the recommended threshold, right? In my endoscopy unit, everybody in the unit's been above the recommended threshold for over a decade. We haven't faced the problem. The literature would suggest that the problems are in the surgeons, and there's a segment of gastroenterologists who aren't measuring their quality. I'm sure that they're a problem too. It's the same kind of thing, of why some people are using hot forceps 20 years after everybody said stop it, don't use them. So I guess it's I think there's probably multiple. I would listen to what you're saying. I think that should be discussed.
Yeah.
You should discuss that because you're still on the executive committee at the board meeting. Fix this.
Yeah. Thank you.
I know there's a,
Great point, Steve. Thank you.
I know we have a bunch of questions. We have 5 minutes left, so kind of do a little rapid fire. So for rectal neuroendocrine tumor, how important is R0 resection? Should be taken out without, with FDRD, helmet or Momin, if you want to answer that.
I don't think so that FTR is necessary for small rectal net kind of overtreatment. We talk about green endoscopy. It can we usually do a quick ESD. You can do a band ligation. Even some publications are on underwater. It's also a high R0 resection rate.
Probably better to not inject them before you band them. Would you agree?
Yeah.
And what is your preferred injectant for cold EMR, Dr. X, if you choose to lift?
Right now I use Everlift. I think a variety of things work. I don't put adrenaline in for the most part, unless I'm trying to shrink some big pedunculated polyp or a really large cold EMR because it produces post-procedural pain. We did a small randomized trial showing this, so I tend to leave the adrenaline out. A lot of people put it in, but we discharge our EMR patients within 45 minutes, same interval that we would a routine colonoscopy. I think there's a lot of things that work and very, very little head-to-head comparisons between the commercial agents.
There's a question on tattoo placement. I think it's probably a good topic to just quickly talk about on where to tattoo, when to tattoo, and tattoo with endoscopic resection versus surgery.
Don't tattoo in the cecum. Take a photograph. If you can see the cecum in the distance, don't tattoo. Generally, don't need to tattoo in the rectum. If you're tattooing before either removing it yourself or referring, put it at least 4 or 5 centimeters away. Don't put too much in. There's a lot of carbon now, like in Spot EX, and 3/4 of an ml is fine. Give you a nice tattoo several centimeters away, and then say in the report where you put it. I put the tattoo 5 centimeters distal to the lesion or 5 centimeters proximal or to the opposite wall. But doc, don't just say that you tattooed it, and try to keep it out from under the lesion.
Yeah, my case yesterday, there was a tattoo really close to the lesion. And this is, I think, if you decide then for a second opinion for resection, it's really hard work for.
It's especially bad for ESD. It seems like everybody doing ESD complains about it more.
Yeah.
But even for EMR, there have been some reports of perforation where the muscle seemed to be tacked well up, to the lesion, and that presumably that's what caused the muscle to get caught.
And then I think it's also important to note that putting it proximal and distal, I think distal is helpful because once the endoscopist is going in, then they know that, okay, it's coming up, whatever, if it's 4 centimeters, 5 centimeters, but they're clued in that they're about to approach the polyp. So distal is very helpful.
Yeah, I like distal too. And for surgery, I would only tattoo distal. Don't tattoo proximal and distal, because then the surgeon has to find 2 sets of tattoos. For surgery, probably good to put more in, and 3 or 4 quadrants, especially in obese men, because from the outside, the cirrhosis is covered with fat in an obese male. So you want to get enough tattoo in that the surgeon, and then your surgeons, so that they can see it. And it's important for your surgeon to understand that if they ever cannot find a tattoo intraoperatively, first of all, that's a message to you that you got to tattoo better. But secondly, you will go, or your team will go whenever and colonoscope the patient in the OR. And I would just say in general, unless you're in the right colon and you can see the cecum, don't name the segment that you're in. Like you see a tumor and you think it's in the descending colon. You say, there's a tumor and I tattooed 4 centimeters distal, and it's in the descending colon. Okay, now if the surgeon can't find the tattoo, you've given them the opportunity to decide that you knew what you were talking about when you said it was the descending colon, and to take the descending colon out and not find the lesion, and then end up taking out another segment of colon or closing the patient. That's basically wrong site surgery, and everybody becomes at risk at that point. So don't name the segment or say, I think it is, but I even say something, you've got to find the tattoo. Whatever language you need to convince the surgeon.
Wow, thank you. What a fantastic session that was. So